Because the midterm has 41.
Yeah, that's what after class today we're gonna be in there tutoring on the ovary. Any questions about anything that's on the board before we get going?
Chapter 42.
Has everybody turned in your homework?
2 homework.
Everybody signed in?
Do we have a quiz?
No quiz. We got time for a quiz. Today we're gonna finish up chapter 42. We're gonna outline it for the homework. Your scan assignment is still due before Wednesday, especially since you guys you had 2 extra days to do it, so it's still gonna be due. And then you got a chapter test on Monday next week. Along with what we're about to go over.
Do you have a copy of 2 extra days?
We're gonna get it.
There, all the extra assignments are on top of the,
Scanning on my
bookshelf. So, there should be one over there.
I don't think it's one or more than just 3.
Yeah, that may be more.
Yeah, well, I made a few extra copies, so everyone should have enough for one, and there should be like 2 extras, so are people taking more than one?
No, perfect.
More than one. Okay, well, we have something we gotta get.
Next one.
I don't know what you got there.
I don't
No,
know.
I asked her if she could give me a copy of our scanning. I got a copy if you want one.
If there's none in there, then I'll have to make another copy and print it off for you. Alright, chapter 42. And we got to, simple cystic masses, correct? Alright, so just highlight that entire paragraph right there. Starting it off right. Alright.
Page 1.
We've already done 42. Oh, starting this.
Alright, an ovary's function is to mature oocytes, which are immature ova, or eggs, until ovulation under the influence of luteinizing hormone and follicle-stimulating hormone, which is that FSH, from the pituitary gland. At the same time, the ovary synthesizes androgens, which is the male hormone, and converts them to estrogens, which is the female hormone. So everyone has estrogen and androgen. It just depends on the level that you have. Of course, females have more estrogen, men have more androgen. Finally, it produces progesterone after ovulation to sustain early pregnancy until the placenta can do so at 10 to 12 weeks of gestation. So our ovaries secrete estrogen, specifically the follicles secrete estrogen on the ovary, ovulation occurs, and then the corpus luteum, specifically on the ovary, is what secretes the progesterone. Alright, next page, highlight that entire next paragraph. Usually only one follicle. This is all just review to you guys. We've already gone over all of this, but it's just a really short, to the point. Usually only one follicle enlarges over about 10 days in the mid to late follicular phases of the cycle. So during the follicular phase, you usually have like 4 to 5 preantral follicles that will mature, but you'll only have like that one mature follicle that becomes a growing follicle that you will actually ovulate from. This is followed by ovulation. The resulting corpus luteum, after you ovulate, that follicle, that mature follicle that actually that released the egg, will become a corpus luteum. The resulting corpus luteum or an abnormal unruptured follicle can persist as a simple or complex cystic structure from 1 to 10 centimeters in size. These so-called functional cysts may produce discomfort or delayed menses, but can be observed to progress within 8 weeks with serial ultrasound studies, so they will go away on their own. That's why, you may have an cyst 1 week, a few weeks later, you may not. If a cyst greater than 6 centimeters persists more than 8 weeks, surgical intervention may be considered. So if you got a big one that's causing issues and it's just not going away, it's not getting any smaller, then it may have to be surgically removed. Alright, let's move over to complex masses. Well, here's a little picture. This one was kind of cool. So we've seen cysts sonographically, but here's one just like a picture of it. Like this would be our follicle, our follicular cyst right here that's hanging off. See how huge that is compared to the ovary? What's on that song? Sonographers doing the dark night. I didn't see that. I see a lot. I saw the conjoined twins. Okay, so here is a big honking cyst. 3.1 centimeters. And see, this is a simple cyst because there's no echoes in there. And whenever you measure the cyst, you are just going to measure all this. But whenever you measure the ovary, you include the cyst. So we would have, one caliber, it looks like the ovarian stroma is kind of going off the screen here, but you probably have a caliber probably about there. And then you have another one out here. Can see this tissue around here? That is ovarian tissue. And ovarian tissue is called stroma. And so you would include this. You have a caliper out here to there to include the ovary. Okay? So don't just measure the cyst and say, oh, the ovary measures that. No, that's not the ovary, that's the cyst. Make sure that you include all the ovarian tissue whenever you measure the ovary. Here's another one. This is kind of more like what you guys are seeing, like the smaller ones. And so you see the ovarian tissue here. So you make sure to include all of the ovary whenever you are measuring the ovary. That medicine's making my lips go numb. Just so you don't know. Like, really? That's weird. I should have taken like a regular dose.
Probably shouldn't have taken so much.
No, it's just it's flesh and I don't take medicine very much. I'm very sensitive to it. Okay. Complex masses. Alright, any simple cyst that hemorrhages is going to be a complex mass because you'll have internal echoes in there. So,
That's right. That's right. Okay. When are they drawing?
they draw Monday of every week.
Two more left?
I don't even know what I see.
Probably be president.
You've got to write your name on the back of the coupon, on the back of the ticket.
Where do we get them?
How do you? I don't know.
You want to keep this?
Oh my God. Hang on. Write your name on the back. Oh God, time out. Okay. I tap out of this day, seriously. Write your name on the back. And I guess they just look it up and tell us, I don't know what they're doing. I don't know.
Okay, just write on the coupon with their name.
That's what I do.
Right on the back of the coupon, because that's the one that we've got to take and give to the president or whoever's doing the drawing.
Also, write on the coupon.
So write your name. No, other one. I got it. I need that one. I think I need this one.
You need the one with the name on it.
Okay. Yeah, that's good.
Right?
Yeah.
Just the name between. I don't even know my own name.
I thought it was the other way around. It's
No.
just Alpha Seltzer, but
I just put my name in the program.
that's what I did when I wrote it for you guys, but I ain't doing that today.
Yeah. You wrote it before.
I did. I wrote your name and you
Okay,
meant.
we keep. Yeah, we keep.
Well, the
the
pin.
name, the
On
line.
each, how do you know which one we have?
Because I didn't give it to you guys, I did it to the seniors, just mine, I was like, yeah, I was like, messing on the seniors.
I
and juniors, guys.
I don't know.
Yeah, the blank, the one without your name.
If you didn't come get it, I have like a handful at my desk because some people never came and got them, so. Larry, why you gotta be the one to mess stuff up?
Because I'm Larry.
Mary Larry. Do you watch VeggieTales?
My favorite one.
No, Larry.
My baby watched it usually.
Larry, you know you just like VeggieTales.
Huh?
You know you GPR those VeggieTales.
Hey! Good storyline.
Okay.
Making sure. You're gonna be calling out now. I was reading that.
See what?
We haven't finished our CPR certifications.
Give me one number 6.
Well, Larry.
I'll make sure like call
Oh, yeah.
Number 3.
It's just Alpha Seltzer Plus. I don't know what it's
Ring of Fire, number 3.
Okay. Is 6 endometriosis?
That's what I was looking for. That's what I thought. I thought it was endometriosis.
You said the what?
I thought it was
It didn't say like,
And
not
say
you guessed it is.
I can stop saying it.
She personally knows. That's why I have surgery. Yeah.
Plus is it
Got it.
nighttime? No.
They're gonna make it-
Yeah, I was saying it's nighttime. I mean, it was purple. No, oh, then purple usually means nighttime?
I'm just saying I said it before and it made me feel like I didn't get that.
I'm just saying plus is.
What is it?
I thought I needed extras. Okay. Where's this thing? Okay, and then also other complex masses that you may see are ectopic pregnancy. The pregnancy may or may not be viable. That was on just start last night, that viable ectopic pregnancy. Those are interesting to see. Most of the time it just kind of looks like a big wad, a big complex mass. They're not usually viable, but you do see those sometimes. Let's see, endometriosis and pelvic inflammatory disease or PID. And the dermoids can also look like complex masses. And here are, this is what a hemorrhagic cyst looks like. You're probably going to see these a good bit, especially if you end up working in an OBGYN clinic. Or really just working, wherever you do GYN, you're going to end up seeing this. And now this actual measurement is an actual ovarian measurement. See how the calipers have included the stroma, the ovarian tissue here? Where you going, Emily? What papers? The paper that you have there. I passed one up to you. Yes, I did. I mean, it was underneath my Let's make sure that's not one of them. Yep, it is. Okay, Brown, Duncan, and Horton. See Miss Bantu after class. Brown, Duncan, who? Brown, Duncan, Horton.
Who's Duncan? Me?
Brother. It's
Probably. Maybe y'all won. Last week.
It's something they got in trouble for last week.
I ain't never known.
Okay, okay, so here's a hemorrhagic cyst. See all these different echoes? Now, hemorrhagic cyst will vary in its appearance depending on how old the blood is. Typically whenever you're doing like a DVT, like the older the clot, the more echogenic it gets. Y'all weren't there yet, though. Oh, you did? Okay, so that's fresh. So a fresh bleed is going to look like what? And then the older that it is, the longer, the more chronic. Even to the point that sometimes it can even become like calcified if it's like super old. Okay, so here is another just complex mass here. And I'm on the solid tumor. Did you watch Family Guy? Like, I'm a tumor, I'm a tumor.
Where's that kindergarten comic time?
Arnold says it's not a tumor.
Oh, yeah. No. You just know that, any cyst that is not simple cyst, it's gonna be like a complex cyst. So if there's any kind of echoes in there, know that it's going to be complex. Oh, right. I got a test on that. I'll put this, I'll put the PowerPoint on for it.
Yeah, because we're not. Might as well wrap it up.
Listen, you keep talking.
Better wrap it up and go home.
All right, wrap it up.
Alright, so for solid tumors, skip the first paragraph and just highlight that first sentence and then the last sentence of the next paragraph. And that's good, it's right there. More sonographically complex the tumor, more likely it is to be malignant, especially if it's associated with ascites. Oh my God.
Middle of the car.
I have to edit
Put it on your. The trigger's like red. It's hard. That's so funny.
Oh my God.
Okay.
You can get through it.
Oh, that's.
Really? Because I'm feeling like warm.
Oh. Take your jacket. Bless your heart.
We need to.
Alright, okay, so this is true about anything, anywhere. About if you see like a complex mass, it's like the more complex appearing it is, the more likely it is to be malignant. And if there's ascites that's associated with it, chances are that it's going to be malignant as well. So something that is like all nice and pretty and round, probably going to be, or maybe not probably, but if the more round it is, the more encapsulated it is, chances are it's going to be benign. But if it's all weedy-wobby, crenulated, chances are it's going to be like malignant. Okay? But what is not malignant and crenulated? We're talking about last week. Kind of look like that. Corpus luteum. Hi, Jamie. Corpus luteum. Okay. And then, solid tumors, they can become large, and sometimes they can even fill up the entire pelvic cavity. Okay, so here is a solid tumor. So see, there's no like anechoic areas where it's fluid, so it's not going to be cystic because there's no fluid there. It's not going to be complex because there's no fluid there. A complex structure is going to have fluid and solid components to it.
Well, see, I would think that was that because it's a black line.
Yeah, that's just shadow. And here's another solid mass. See, there's no cystic components to it. There's some hypoechoic areas, but that's not cystic. Okay, Doppler of the ovary. Highlight the first line. When any abnormality of the ovary is detected, Doppler examination should be performed. So whenever you see a cyst or some kind of mass, anything you see abnormal, some kind of pathologic process, you need to put color on there. And then differentiating a potential cyst from adjacent vascular structures is something that you could do. I think on somebody, Ms. Abels was telling me, thought it was the ovary, so they put color on there. Instead of being follicles, it was the blood flow. It was a vessel. So that's another reason why you always want to put color flow on there, because you may think those are follicles, or maybe it's a big follicle or a cyst or something, but you put color on there and really it's a vessel. So always Doppler. Put color Doppler on there whenever you think there's something, you know, possibly pathologic or abnormal about it. I know nothing else like that too. I was like, I think I'm not so delete this. I usually delete all the crazy stuff. Okay, so go down to the next paragraph and skip the first 3 sentences where it says intratumoral vessels, low resistance flow, and absence of a normal diastolic notch in the Doppler waveform are signs that may be worrisome for malignancy. So whenever you see a tumor, some kind of mass, you put color on there and you see that there's vessels that is lighting up with color, that tends to lean more towards a malignancy. Because, you know, cancer has to have blood flow for it to grow and spread and to get where it doesn't need to be getting. An absence of a normal diastolic notch in the Doppler waveform. Oh wait, I got ahead of myself. Low resistance flow. So that means you're going to be needing more blood flow. We're just going back over that same sentence. Low resistance flow. So the cancer, if it is a malignancy, is going to be needing more blood flow, so you'll have a low resistance waveform, and therefore you won't have that normal diastolic notch. It'll look like a high resistance waveform, like this. You won't have like this little low, high resistance doodad waveform. Okay, next page. Alright, let's skip over to that second paragraph of the next column, where it says a mass showing a complete absence or minimal diastolic flow is usually benign. So here if we see a mass and there's absolutely no blood flow in it, or if there is some blood flow but there's a very minimal diastolic flow, meaning that the blood flow that's in there is it's a very high resistance type of flow, then chances are it's going to be benign. Alright, let's move on to function. Okay, well, I got some pictures. Hang on. So here is airway. Hang on. Okay. That was meant for me. Alright, so see how there's like a little diastolic notch? Like right here, you're not going to see that with a malignancy. It'll look more like this. Okay, functional ovarian cyst. I like the first 3 lines where it says functional cysts result from the normal function of the ovary. That's what we've seen a lot of in your class. You'll see the cysts, and eventually they'll go away. Those are just normal functional cysts. They are the most common cause of ovarian enlargement in young women because you include the cyst whenever you're measuring the ovary, and therefore it's going to make the ovary measure enlarged. Functional cysts include follicular, corpus luteum, hemorrhagic, and thecalutean cysts. So all of those are types of functional cysts. Most cysts measure less than 5 centimeters, and they regress during the subsequent menstrual cycle. So they usually don't get more than 5 centimeters, and then they do go away or they regress throughout your cycle. So moving on to follicular cysts. It forms when a mature follicle fails to ovulate or involute post-ovulation. So you know probably about 4 or 5 follicles become mature, but only one of them actually releases an egg. Usually, however, we know we have twins, so more than one can ovulate. But usually there's just one that does, and then the rest of them that don't actually ovulate will, they'll involute and they'll kind of just go away. However, sometimes they don't always go away. It takes a little bit longer for them to go away. And so that will be a follicular cyst. And they are typically unilateral, and it's typically the ovary that you ovulated from. Patients are usually asymptomatic because they're typically small, they don't cause a problem. However, if they do rupture, you may feel like some sharp, but maybe kind of dull pain to it on that side, just depending on how big it actually was. And then you may see some fluid in the posterior cul-de-sac. And that's normal. Your body will just resorb it, and you'll be all right. But again, typically these follicular cysts are less than 2 centimeters. That's why you usually don't feel, they usually don't cause a problem because they're so small. And again, they do regress spontaneously. And these follicular cysts look like simple cysts. Does everyone remember parts that I taught you guys last quarter about the sonographic appearances of a simple cyst?
Yes, about the terminal anechoic.
Hang on, let's do it together. Everybody get this written down?
No, okay. It's in our email.
Okay.
Miss Bandu.
Yeah, posterior.
Posterior.
Enhanced.
That website.
Very good, guys. I did this with the seniors and like, okay.
Can you put that on the test?
Yeah.
This?
Yeah, we all know it because we thought it was gonna be on.
It's maybe. It might be. I have to check because I do have short answers. Maybe.
Oh, boy.
No, wait, that's not y'all. Never mind.
Okay.
You have another test.
Maybe.
That's right.
Okay. Corpus luteum cyst. Result from failure of resorption or from excess bleeding into the corpus luteum. These cysts usually are less than 4 centimeters in diameter and are unilateral, because that's where you ovulated from. If the ovum is fertilized, the corpus luteum continues as the corpus luteal cyst of pregnancy during the first trimester of pregnancy. But when maximum size is reached by 10 weeks, it resolves because the placenta is taking over and providing hormones needed to sustain the pregnancy and the blood flow and all that good stuff. You won't have a yolk sac anymore. You won't have the corpus luteum either. So it regresses after the first trimester of pregnancy. But if you don't get pregnant, then it just involutes and the body resorbs it. Down to sonographic findings, they usually appear as complex masses with central blood clot and ectogenic septation. They're difficult to distinguish from ectopic pregnancy and endometriosis. However, again, we were talking about the ectopic pregnancy that's on an ovary. If it's a real big corpus luteum and you can't see any ovarian tissue around it, then that's kind of a different story. But usually you can see some of that ovarian stroma around it that we looked at, even with that big honking cyst that we saw, the hemorrhagic cyst. We still saw ovarian tissue around it. So look for that. And also just know that, if you do see ovarian tissue and it's hanging off the ovary, know that an ectopic on the ovary, chances are it's going to be corpus luteum instead of ectopic, because the sperm would have to go all the way through the uterus, through the fallopian tube, go out into the annexa, and just miraculously find that egg as it's just being ovulated, and as it's just like coming out of the follicle, and before it's getting into the fallopian tube. So all sorts of things have to go right for it actually to happen. Okay, ectopics typically occur in the fallopian tube. Okay. Okay, but it does have that ring of fire. Which is just the same as an ectopic. They both kind of have that ring of fire appearance. So here's another corpus luteum. I showed you some pictures last week. But here's another corpus luteum cyst. That's kind of the typical what you see. And then you see ovarian tissue all around it. I thought I had a little blood flow. Okay, I'm sure it's here somewhere. Okay, next page. Hemorrhagic cyst. Let's skip down to sonographic findings and just highlight that first line. The sonographic picture is variable depending on the amount of hemorrhage, top formation, and time passed since the hemorrhage. Kind of already talked about that. The appearance changes with age. However, the thing with these hemorrhagic cysts, they're actually flipped from what you would think of like with DVT. So same thing with like an annexal bleed and an adrenal bleed. You know, a lot of these things like in the abdomen, they'll look flipped. So it'll be hyperechoic and then it will become hypoechoic. And as time goes on, the internal pattern becomes more complex. And a ruptured or a leaking hemorrhagic cyst can cause like blood to get into the pelvis, and you'll actually see like instead of like just anechoic fluid and posterior cul-de-sac, there'll actually be like echoes in there, and that's because it's blood. Gotcha, I love that. If you guys are doing that Syntex thing, if you do the transvaginal, don't have your kids in the room, because apparently it's like full on. Like, okay? Yeah, so that might be like once kids
They're
come
trying
in.
to buy us a website where you can do it like virtually on the computer, like and be around.
Damn, virtual.
Instead of a mouse. Yeah.
But then her school's gonna pay for it, so she wants you to go online and tell her if you want it or not. Yeah.
You know what I mean? It's not
Yeah,
gonna
but I
get
can't
it.
put my
It's
mouth
not,
on your
no,
computer.
because it's not gonna get the angle.
Yeah.
No, but the main point of it is for things that you don't normally get to scan, like scrotum, breast, transvaginal,
Right.
those sort of things. And also it's got pathology.
That's true too.
Know everything back, where to be at, to see it.
I'll take any kind of
Okay. Speculoosing cyst. Oh, there's another hemorrhagic cyst.
Where was the ruptured hemorrhage, whatever?
Oh, that's under sonographic findings. It's like the very last sentence, so that it can mimic the ruptured ectopic pregnancy. Because an ectopic pregnancy, once it ruptures, you're going to bleed, and it's all going to go to the most dependent portion of your body, which is the posterior cul-de-sac. Yes. All right, so just assuming nobody's heard me say what this was, what is this?
That's an ovary.
Good job, Emily. What is the pathologic process on the ovary? Hemorrhagic cyst. And there's another hemorrhagic cyst. And that's just there, kind of looks like spider webs to me, kind of in there. That's just what your typical hemorrhagic cyst looks like. Okay. Alright, so speculoosing cysts are the largest of the functional cysts. These can actually get really big. And they appear as large, bilateral, multiloculated cystic masses. So it's not just going to be one big honking looking cyst. You're going to have a multiloculated, meaning there's going to be a bunch, and it's going to be really big. And it's bilateral, so you'll have it on both ovaries. And this is important to know about speculoosing cysts. This is what is specific to them. They are associated with high levels of HCG, and they are seen most frequently in association with gestational trophoblastic disease, and that's like a molar pregnancy. It's where, which you'll learn more about when you get an OB, once fertilization occurs, you transmit the zygote, and then you get all these like trophoblastic cells that start multiplying. Sometimes they can just over-multiply and just go crazy and you end up with a molar pregnancy. You can have either a partial or a complete molar pregnancy, but you're going to have increased HCG levels, and so that can cause these speculoosing cysts to occur. Also, multiple gestations can do it. You got more than one baby in there. That's a lot of hormones going on. So you're going to have decolletage cysts with those as well. And then this is what they will look like. This is the multiloculated. See how it looks like multiple cysts? It's not just one. It looks like a ton of cysts all right there. But that's a multiloculated cyst. And this is both ovaries because they are bilateral. This is their right, this is their left. Here's another one that's just showing a single ovary. See the ovarian tissue there?
Do we have to measure those? Do we have to measure individual?
Oh, no. See this right here, this is measuring the whole thing, because this is just a multiloculated cyst. So this is like one big cyst, it just has all these septations in it. Alright, so this is a molar pregnancy. This is what it will look like. So here's the endometrium, and you'll learn more about this too in OB, but I just wanted to show you guys some tissue. I don't really know what they're measuring here. Maybe it's the thickness of the uterus, maybe? I don't know what they're doing here. But this is like the grape-like, is what they'll call it, like a cluster of grapes, is what it will look like, and you'll just have all these like little circles, circles throughout right there. And here is a partial molar pregnancy. So here's a profile of the baby, and then you've got the molar over here. So this is just a partial molar pregnancy, whereas this is a complete. Okay? No, there is no, wait, in this one or this one? This is a complete molar pregnancy, so there is no baby in this one. The trophoblastic cells just went crazy, and this is what you got. But whereas here you actually have a viable baby. That's a partial molar pregnancy. And again, you'll just see the decolletage cysts with this. You'll learn more about this when you get to OB. But with these type of pregnancies, you'll see those decolletage cysts.
I'm confused about this. You said both women is pregnant. So in that one, what's the baby? Is no baby?
No, there is no baby. This is a complete molar pregnancy. No baby formed. This is all that you got here. Those trophoblastic cells went haywire.
But she's still considered pregnant.
Yeah, it's not a viable pregnancy.
That's confusing.
No, but this baby, is he gonna make it?
Depends.
Will it be normal, or will it have something?
It depends on the severity. The chances are is no. The probably of having deliver too early. Miracles happen every day. So.
But I don't understand, is it something connected to the baby? I'm confused on what this baby is.
Okay, let's just skip the molar pregnancy. I thought that'd be something cool. Let's just stick to the decolletage cyst. Alright?
I thought the baby was come out with some big cyst cut off of it.
No, this is not gonna be connected to the baby. No. No, it's not gonna have a big cystic arm or something. Okay, let's go back. Let's just get back to ovaries. Ovarian hyperstimulation syndrome. Do what?
You weren't ready.
Look at all this, they're going, where's molar pregnancy? Yeah.
It's a gestational trophoblastic disease. It's just a molar pregnancy.
Okay.
Everybody usually says molar pregnancy. Kind of like leiomyoma and fibroids. Still people just say fibroids. And here, we say molar pregnancy. But it's the same thing as gestational trophoblastic disease.
You told me I will happen.
Good. I don't know.
You were saying it very fast.
Okay. Ovarian stimulation syndrome is frequent iatrogenic, I guess that's how you say it. That's whenever you get something from some kind of something that you're getting. From if you're getting something treated, it's like hospital cause. Like someone gave it to you. Like it's a hospital cause, like you've had surgery and you got staph from it, that's going to be iatrogenic. This, or if you're taking a pill to do something, but then it causes this, then it's going to be iatrogenic. It's like a side effect. I don't know. I need a dictionary. it's hard to describe certain words. You know what I'm saying? But it's like, okay, so say like ovarian hyperstimulation syndrome is usually due because maybe you're taking some medicine to actually stimulate your ovaries if you're like having infertility issues, and they're giving you medicine to do that. Well, it can cause this hyperstimulation, and then it's iatrogenic. Got it? Okay. I can't explain the words. I can, Okay. In a mild form, a patient presents with pelvic discomfort, and maybe even like some fullness, but there won't be a super significant weight gain because it's not going to be that big. However, the ovaries will be enlarged. They can measure more than 5 centimeters in diameter. And with severe hyperstimulation, patients, they'll have like severe pelvic pain because it'll be impinging on all kinds of structures, maybe even those iliac vessels, and can even maybe cause like leg swelling. And there'll be abdominal distension because you've got these huge ovaries in there, and especially if it is severe hyperstimulation. So then you'll have these notably enlarged ovaries that can measure more than 10 centimeters in diameter. Okay. And here is a hyperstimulated ovary, actually 2 of them. So see, this is the uterus right here. And see, these are the ovaries. This is one, and then this is one. It's hanging off the screen, actually. So those are big. So there's probably going to be some distension. You may even be able to feel them. So that's really big. That's not normal, if you see that.
How can you tell that those are ovaries and
Good question.
Good question.
It will be because typically it is iatrogenic. So if you've got someone that is on like ovarian stimulation medicine, it'd be like a clinical thing. If you were just going off this image, you wouldn't be able to really tell. But you'd have to go off of, are they having infertility issues and they're taking medicine to cause the ovaries to increase in their size. So that's like where the clinical stuff comes in, and where you have to read the chart before you start scanning. That's a good question.
What's that little worm-looking thing?
Septation. Ascariasis. I'm kidding. Ascariasis is when it's like in the GI and it gets into the biliary system.
See, that wasn't a joke for us, 'cause we don't know.
It's a worm. Ascariasis is a worm.
She's like, LOL.
That's hilarious. Y'all will get it one day. Still, but do y'all not like find yourself making like jokes and it's like funny to like no one but you?
Yeah.
But when y'all are together, it'd be funny. Okay. Polycystic ovarian syndrome. This is something, especially if you work in an OB/GYN clinic, that you are going to come across. And this is an endocrine disorder that is associated with chronic anovulation. So this patient that has PCOS, they're not ovulating. And this is because of an imbalance of luteinizing hormone and follicle-stimulating hormone. And it results in abnormal estrogen and androgen production. Pathologically, the ovaries are rounded, usually 2 to 5 times normal size, with an increased number of follicles. So PCOS ovaries they're really easy to find because they're going to be enlarged and you're going to have multiple small follicles. PCOS is a common cause of infertility. That's in the last sentence of that paragraph. And on sonography, the ovaries appear normal or enlarged with echogenic stroma. Multiple small follicles are seen often bilaterally. So typically, most of the time you're going to have, if one ovary is PCOS, the other one is going to be as well. Multiple small follicles are seen often bilaterally in the same range, in the size range of 5 to 8 millimeters. So they're not going to be super big. These are just going to kind of look like normal follicles. There's going to be a lot of them. And a specific finding for polycystic ovarian syndrome is that these follicles, these little polycysts, all these little cysts are going to be located peripherally in the ovary. And that's a very specific PCOS characteristic. So the follicle is usually located peripherally, commonly referred to as the string of pearls. But if you had like black pearls. Okay, so this is what it's talking about. See how this looks kind of like a little string of pearls? We got multiple little follicles that are going to be like around the periphery of the ovary. See how the ovary looks, you know, kind of enlarged there, a little prominent. Here's another one. See, they're peripherally located. Here's another one. I saw that. I thought it was cute. My ovary right there. There's something ovary right See, y'all are nervous. No, I wouldn't laugh at that. Okay, peritoneal inclusion cyst. Wait, let's talk about ovarian remnant syndrome real quick. That's just like what it, in its name you kind of figure out what it is. This is a cystic mass that is seen typically after a bilateral oophorectomy, which is where the ovaries are removed. So this is where, you know, you have the ovaries removed, but there's some ovarian tissue that gets left behind. And this is typically, I mean, if you have just this normal ovary, or not really normal, but if it's not like attached to anything, it just simply comes out, then you're not going to have any extra tissue. But if you ever try to pull, I don't know, like maybe paper off of a Tootsie Roll or something and some of it gets stuck, well, kind of think of it like that, like if some of the ovary is still stuck on there due to like some kind of adhesion. Maybe they had issues with like endometriosis and they had multiple surgeries, or they had you know, ovarian carcinoma, they had like resectioning of it. But some of the ovary was like stuck to all these different adhesions, and some of the ovarian tissue got left behind. Well, that's still functioning ovarian tissue, so a cystic mass can form, and that's just and that's going to be that ovarian remnant syndrome. So it's what is left over, that the remnants of the ovarian tissue. So that's just kind of like in its name, so we'll kind of tell you what it is. Okay, next page, 1010. Peritoneal inclusion cysts. They are formed when adhesions trap peritoneal fluid around the ovaries. So these are not actual true cysts. These are adhesions.
Well, they didn't even draw the last.
Yeah, you get for every day. I don't know why you got more. You get you get 3 per class, so you're getting them for all the week.
Well, we're not gonna
I
do
don't
that.
know, what kind of incentive is this? Is this supposed to be so I come to class?
Yeah.
Oh.
We're supposed to tell you that. We're supposed to say, hey, it's to get you to come to class. So that's what it is. But then, you know, you get them anyways. I think you're only supposed to get like 1 per, you know, you come to class, here's the chance.
Yeah, I was in class at 3, my first class.
We don't care. I mean, we do, but you're still going to take it.
day. And you can hang them while they're still in the class. Oh, I'm supposed to keep that one. There's 3 words in there. Oh.
So you left your blue marker in the lab. I think.
Oh, okay.
You dropped your keep on someone's line. Somebody did, I think.
I wouldn't know if they drew or not anyway.
Yeah, I mean, how would you know?
Yeah, that's what I wanna, how do we know? I don't know. Well, I mean, they can't call us or anything.
Well, this time, they had.
Well, I put my phone number on there. They
Okay.
need to find out.
Okay.
I mean, I don't think I do this class. I mean, is it just for our program? Or
She
is
told us
it-
to take the test.
Yeah, she said it's a little.
No, they have the other one and you have one,
they're
and you just read your ticket and see if the numbers match.
Yeah, last week I got 6 of them.
Last week they were just.
It sounds like it.
Yeah, just take them.
They didn't even match. Me and her split it up. She kept one half and I, and.
It's $100 a week.
She splits them down
Huh?
and she keeps one half and gives us.
Oh,
The billion tickets.
Well, that's what they
Yeah,
for,
that's what it
cause, well, I mean, I'm not lucky anyway, but you know.
The keep.
Alright,
Yeah,
where were we?
we're never gonna.
Okay, peritoneal inclusion cysts.
That's
Alright, so these aren't true cysts, they don't have like true cystic walls, true walls. These are due to adhesions that have caused fluid to get trapped around the ovary. And these can cause pelvic pain or even a pelvic mass. If they're large enough. You can like feel it and be able to palpate. And this is multiloculated cystic adnexal mass is what it will look like. Here they've got a picture of one in figure 4213. That's a peritoneal inclusion cyst. It's not actually a part of the ovary, it's just trapped around it. And the arrows are actually pointing to some of the adhesions that are trapping this. And these predominantly occur in premenopausal women with a history of abdominal surgery. And so it's just like the ovarian remnant syndrome. Typically there's been like surgeries and issues before, and so these adhesions have formed. Yes, Emily?
I really have a true question, Brooke. Okay, if you have a partial hysterectomy, they leave your ovaries, okay?
Yes.
Can you get cysts on them?
Yes, but they're still functioning.
Yeah, I know.
My friend had that thing.
Emily, my friend had a full hysterectomy, but they left remnants of the ovary and she grew cysts all.
Well, see, I was talking to my mom last night, and she had a hysterectomy, but I didn't know it was partial, and she was telling me they left her ovaries.
Yeah, it's so because if you take the ovaries out, you have to have hormone replacement. It's because your ovaries produce your estrogen. And if you don't, you'll grow a beard and...
Well, that makes sense then. So do they pretty much all the time do partials? Unless they just...
What?
Usually.
They do partials unless they just have to take ovaries then.
If you're at a risk like ovarian cancer, I go ahead and take them ovaries out too and just take you some estrogen. But, okay. Where's my clicker?
I'm trying to.
Thank you. Okay, so here's the peritoneal inclusion cyst. We can't see it, this isn't so honking, we can't see the ovary. But here's our uterus. And see all of these adhesions here and all this fluid that's trapped. This actually could be blood since there's some echoes in there.
We know what you're saying.
Yeah.
Okay, or it could be like infected fluid, so. But it says uterus.
I hope all of my patients.
Oh, y'all are killing me. You got your tissue, your endometrium.
Where is that little bitty thing for endometrium?
Right, it says uterus, it's what uterus.
That's why, but what if
They
that's
had
not
uterus
real?
surgically implanted on their uterus.
Which
Yeah.
one? That little bitty wormy looking white
Yeah.
thing.
On top of the.
Like all that.
All that is?
Yeah, all the way. Yeah, all the way.
Oh my dear.
I did check that.
Yeah, that's what I That looks like a leaf.
What are we looking at again?
That's an ovary.
Peritoneal inclusion cyst.
Right.
Okay, so here we've got a normal right ovary, and here's the peritoneal inclusion cyst here.
Wow.
So we've got our normal little right ovary here, left, and then right there.
Oh God, it looks like a second bladder.
Yeah.
It does. And that's why if you can't tell, you may need to get your patient to go like empty, just to make sure.
Make sure their bladder's not full.
Well, just make sure that's not the bladder. I mean,
Because
you
that's
can,
not gonna empty.
yeah, it won't empty. But also, if you kind of know what you're looking at, I don't know, maybe their ovary could hang out up here by their bladder. But just if you're not sure, a little confused by any kind of cystic mass, I'd have them go make sure they empty their bladder and then recheck after you got all your pictures, because you don't want to empty their bladder and you haven't yet measured their uterus, so do that at the end. Okay, para-ovarian cyst. Highlight the first two sentences. Para-ovarian cysts account for approximately 10% of annexal masses. So again, these are things that we're checking whenever I get you to do your anexa images. You get it in grayscale because we want to see if there's anything, these huge cystic masses there. Put color on there. We want to make sure that the iliacs are lighting up. We also want to make sure nothing else is lighting up. And if it's not, it's a cystic mass. So there's multiple reasons to look for that. And then these arise from the broad ligament. So what portion of the broad ligament, what's it called that goes over the ovary?
The mesothelium.
Good job. What about over the fallopian tube? Mesothelium. Good job, guys. You guys do absorb some of the things in my class.
Until it gets on my chest.
So when it counts, all right. Down to sonographic findings. Para-ovarian cysts have thin, deformable walls that are not surrounded by ovarian stroma. It's not going to have that ovarian stroma around it because it's not part of the ovary. It says para-ovarian, so it's like just an anexa. It's around it. It's out there hanging out on its own because it comes off the broad ligament. And these, of course, can vary in size, and they can arise anywhere in the anexa structure, anywhere out there, just not on the ovary. All right, let's just skip all of the rest of this page. And let's go to endometriosis. So here's us, a para-ovarian cyst. So here's our left ovary. See, it ends right here, and then our cyst is over here. So this is where it would.
I missed all of this. I don't know how it happened.
Okay. I've noticed in the past you just don't fill them out.
I'm paying attention, so I missed it. And I look over at hers, and she's got like half the sheet done.
I get, like, when we look at the images, I'll look and search, because that way when I look at it, I don't have to, when I'm up here. I'm done with this. So she thinks that we're way ahead, because I'm like 2 more ahead of what we're
I'm sorry.
Alright. Here's another one. Here's another left ovary. This is way out here. There's no ovarian stroma around it. Here's the close back on there. So there's that one, and there's that one. We got our left. Here's our left ovary. There's our para-ovarian cyst. Alright, endometriosis. Highlight that first sentence. It is a common condition in which functioning endometrial tissue is present outside the uterus. So you've got endometrial tissue outside of the uterus. What is it called if it's in the myometrium? It's still within the uterus, but it's on the endometrium. We learned it last week or before. Myometrium. No. Adenomyosis.
Oh. What's the add-in stand for? Like medical term.
Is this a medical terminology question? Adeno. I don't know. Ask what's fun. Adeno. I don't know what adeno means. I guess it's just like a tissue, the type of tissue. That's what I would guess. Wait, there's a page. Oh, not this book. endometrial tissue cyclically bleeds and proliferates. So this is endometrial tissue, even though it's outside of the endometrium, it still is functioning. So it's like getting thick and it's shedding. And there are two forms of endometriosis. You have the diffuse form and the localized form. The localized form is called an endometrioma. The diffuse form is the more common form, though, and it consists of endometrial plantings within the peritoneum, and it is rarely diagnosed by sonography just because it blends in with everything. The localized form consists of a discrete mass called endometrioma or a chocolate cyst. Here, called a chocolate cyst as well. And these, however, can be seen just because it's, you know, it's a mass. And can frequently be found in multiple sites. Let's move over to sonographic findings. Endometriosis may appear as bilateral or unilateral ovarian cysts, and they can be anechoic to solid. However, again, you know, we can't say like, yes, that's endometriosis. That's not typically diagnosed by ultrasound. The ovaries are typically adherent to the posterior surface of the uterus and stuck in the cul-de-sac. So, if this is like our uterus here, and here's our posterior cul-de-sac, it's like the ovary is kind of like stuck right there. So if you're looking at your midline uterus, you still see like ovary right here. It's just kind of like stuck hanging out there. It can normally be in this location too, though, but it can also abnormally be in this location.
Why, of course, why would it be a rule?
There's not a known cause for endometriosis.
No. It's thought to either be like, well, it says what the possibilities of it is in the next, you know, within those two, that paragraph before that, but no one really knows. It could be like, you could be like menstruating in the opposite direction, like your blood's going up into your fallopian tube and out to the nexa. That is the thought, and then also down, like broken down like the cellular level. It has to do with the cells and, you know, the biology of it all, but those are just, nobody knows for sure. Okay, moving over to the last paragraph of the endometriosis section. Highlight that first line. So the endometrioma is a well-defined unilocular or multilocular, predominantly cystic mass containing diffuse, homogeneous, low-level internal echoes. So it kind of just looks like chocolate, yes, chocolate syrup, maybe.
Well, I'm lost.
So here is an endometrioma, or our chocolate cyst, or our localized endometriosis. See how you've got these homogeneous echoes within there? Someone just turned their day down, though. Here's another one. So that is, both of those are an endometrioma. But again, you know, just with ultrasound, we can't say like, oh, that's endometrioma. Yeah.
Crim. What we
Let's
looking
see. An endometrioma.
So we in the uterus.
Don't we out there in the nexa.
Oh.
This is gross.
This is in the less than nexa specifically. Endometriosis is going to be like outside of the uterus, but if there's endometrial tissue that has like invaded the myometrium, then that's adenomyosis. This is going to be like out there in the nexa somewhere. It could be like hanging off the ovary, off the broad ligament, maybe off the fallopian tube, I mean just anywhere out there.
I have pictures from my surgery from the laparoscopy.
The nurse couldn't really tell me what any of it was.
She couldn't?
The doctor never came up to me. They were talking to my parents, and then after I woke up, she had been gone, and I was just like, oh, yeah, cool, I didn't want to know any of this.
Ovarian Alright, so highlight the next three sentences. Torsion of the ovary is caused by either partial or complete rotation of the ovary on its vascular pedicle. So it's either, the ovary is either going to partially twist or completely twist. Torsion usually occurs in childhood and adolescence. I guess because, then, you're doing a lot more moving around. 70-year-olds not going to be doing cartwheel. So, and then it's also more common with those that have like a mobile anexa, like the ovaries, they kind of float around and can move a bit more. Ovarian torsion produces an enlarged edematous ovary, usually greater than 4 centimeters in diameter. So, same thing goes with like testicular torsion. Whenever it rotates, or the ovary or the gonad just rotates around, it'll swell up, and then it'll eventually start to atrophy if they don't have surgery, because you have to have surgery when you have torsion. So it'll be real edematous, so it'll be like hypoechoic. And there can be multiple tiny follicles that are around a hypoechoic mass, which would be the ovary. But the most common presentation is that of a completely solid adnexal mass. And then free fluid is often present in the pelvis, so you may see fluid in the posterior cul-de-sac. Doppler examination will reveal either no blood flow at all, which that will tell you, yes, there's torsion, it's a complete torsed ovary. But also, you may be able to see some flow in there. It may be due to just a partial torsion, and where the ovaries have dual blood supply. They get blood from the ovarian artery and the uterine artery. So maybe the ovarian artery got torsed, but the uterine has not. So it's still getting blood flow through that one. However, they still need to go to surgery and get it fixed.
Mrs. Crim, what's the prognosis for that?
It depends on how long it takes you to, the hour, I don't know the specific hour for ovarian. Like for testicles, you have to get those rotated back around within 6 hours and you're going to lose it all.
Surgery?
So, surgery. You have to go in and they just have to rotate it back around and make sure that you're getting blood flow back to it. The ovaries is probably going to be about the same time, but you've got to get that thing rotated around pretty quickly. That's why it's like considered an emergent procedure. So they'll come in, you'll get called in. That's when you'll get called into the emergency room for ovarian torsion, or if someone has like severe pain. Typically, it's just a ruptured cyst and they're fine, but it can be torsion, so you have to check for that. And you put blood flow on it. To code off over, and they check it. But you're not gonna die from it. I'm just saying. You can either get it rotated back around to save the ovary, and if you don't ever go, then it'll become real edematous. And if you don't go to the doctor and they don't do surgery to it, it will eventually atrophy and become real small and non-functional, and you won't be able to find anymore. So
What does it mean to have a bunch of stage ruptures? Like it happens before?
Well, it depends. If you have like polycystic ovarian syndrome, that could be that. Also, you could just have like hyperstimulated ovaries, and that could just be due to, maybe you had an issue with like the pituitary gland, and it was producing too much, it could be producing too much of that FSH. So it's just like case to case, depending on what's going on. And then maybe someone's just super fertile, and they just get lots of follicles that mature.
I constantly have stage ruptures. I had 2 more ruptures in my life. Like you said, I had. Because the sac was full. Well, not full.
Yeah, on the back.
Cul-de-sac. Yeah, but I've had this my entire life, and they've never ever had them removed. I just feel that pain on the right side every single month. They never feel it all the time.
Maybe you just ovulate from the right all the time.
Somebody when we were looking at me the other day, I told her to look at my big small, maybe the other one, that's a couple hours to the right, but that's what I think. I think I do some ovulate from the right.
Yeah, because it's not proven. People kind of think you ovulate from the left one month and the right from the other, and you kind of alternate. That's not really proven. Everybody knows that for sure. So, just one of those medical mysteries. Okay, keeping on ovarian torsion. Where are we? Okay, after it says box 42.9, Okay, occasionally you can see blood flow if there is only partial torsion, due to, you can have dual blood supply, but also it could be because of venous thrombosis, leading to symptoms before arterial thrombosis. So the vein may be getting cut off and the artery isn't. And so thrombus in the vein has formed, but not into the artery. So you may be still getting arterial blood flow there, but it's not being able to get back out. Okay? So when that happens, you're going to be able to see an enlarged edematous ovary. You'll still just be able to see blood flow. And this is when someone starts hurting, they come in to the doctor. So this is like early on. All right, so next paragraph, skip the first sentence and then highlight the next three. Ovarian torsion is an acute abdominal condition requiring prompt diagnosis and surgical intervention. So you've got to get it diagnosed, got to get it treated. They have to go to surgery to rotate that ovary back around so they don't lose it. The ovarian pedicle partially or completely rotates on its axis, compromising the lymphatic and venous drainage. This causes edema and eventual loss of arterial perfusion with subsequent infarct. Next page. Skip down to the next paragraph. Highlight the first sentence, where it says clinically acute severe unilateral pain is typically the presenting symptom in patients with torsion. So if the left ovary is torn, you're going to be hurting on that side. So it's going to be that unilateral pain. Typically you're just going to have like one ovary get torn. And then whenever you have like severe pain, nausea and vomiting tends to follow. Like even if you have like a bad migraine, you tend to get nauseous and vomit. Fever can also occur. A palpable mass can be felt in more than 50% of patients because again the ovary gets real large and edematous. So you, just with pushing down over the pelvis, over where that ovary is, if it's your right ovary, you push on over here, you may feel it. And then the right ovary is 3 times more likely to torus than the left. I don't know why. I guess just because most people are right-handed, maybe. I don't know. That just seems, that sounds right. Sounds good. Sounds good. That's how I always remembered it. Like more people were right-handed than I. You write with your right hand, so your right ovary is going to get torus. Okay, torus ovary typically is enlarged and heterogeneous because it becomes edematous. The vessels are going to get dilated within, and this is owing to edema. What? Torus enlarged and heterogeneous in appearance, owing to edema.
I guess we could look at that other.
I know that's what I was about to do.
That's what it says.
There's a lot of typos in this book. And a lot of our books, actually.
That's owing.
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 Okay. And then it often leads to a mass. So this is just kind of like re-summarizing all of the stuff we just talked about. Okay, so here they torched the ovary. I think I'm showing you guys this picture already. See how there's no blood flow in here? And another thing that can cause an ovary to torse is a mass or a cyst, something hanging off of it. Because if you think you've got your ovary, you got a big old mass hanging off here, and it's hanging out, and then if it gets to be too heavy over here, it'll flip like this and cause it to torse. And so this little cyst right here, hemorrhagic cyst there, looks like it's probably going to be the cause for this edematous or heterogeneous ovary here. Here's another one. See how goopy that looks? All heterogeneous, not pretty at all. No blood flow within. We got a little speckle there, but that's why I just put the colors up there. Okay, sonographic evaluation of ovarian neoplasm. Highlight these second and third sentence. Only 3% of ovarian cysts less than 5 centimeters are malignant. Therefore, it is recommended that a cyst greater than 5 centimeters be surgically removed. So if you have a cyst that's less than 5 centimeters, it's going to be benign. However, 3% of the time it'll be malignant, so that's a pretty low number. So typically nothing's done about it. However, if this is over 5 centimeters, the chances of it being malignant grows. So you may need to have it taken out, because some cancers, ovarian cancers, can be predominantly, or most of them are predominantly cystic. So skip the next sentence and highlight the next. Well-defined anechoic lesions are more likely to be benign. Lesions with irregular walls, thick irregular septations, mural nodules, and solid echogenic elements favor malignancy. So this goes back to that like circle that I drew. That's that well-defined anechoic lesion. Just looks like a cyst. Those tend to be benign, but the ones that get all crazy looking, or chances are they're more malignant. Let's see, Doppler examination shows a low resistance waveform, because if it's going to be malignant, you're going to have that low resistance waveform. And any change in ovarian echogenicity or volume of more than 20 milliliters should be considered suspicious. How big can an ovary become and it still be considered normal? We went over it last week. 22 cc cubed. Good guess. So 22. Here they said 20, but this is kind of the upper limit. From 22, that's pretty big. So around here, you're starting to get kind of in that upper limit where you start maybe getting suspicious. See, is this a pathologic process? Okay, ovarian carcinoma. So skip down to where it says ovarian carcinoma is the leading cause of death from gynecologic malignancy in the United States. So it's more common than uterine cancer, more common than fallopian tube cancer. Carcinoma is fallopian tube, which is the least most common. The 5-year survival rate is 50% if the cancer is found early. However, the survival rate is 93%, but less than 20% of cancers are actually found at this stage. Ovarian cancer is considered a silent cancer, and that's because in the early stages there's not any symptoms. So whenever ovarian cancer is found, it's typically in an advanced stage, and so it's kind of too late to really do anything. But at the time of initial detection, half of the women are usually already in stage 3. So it has already kind of spread into the abdomen. And it's a lot, and just with any cancer, once it has spread kind of beyond its main organ, it's even harder to treat. But ovarian carcinoma can present either complex, cystic, or solid, but it is more predominantly cystic. Pretty sure that's one of the things on your face. Cystic. Predominantly cystic. But this is like with any cancer, they can be complex, cystic, or solid. Alright, masses less than 5 centimeters in its longest axis are more than likely benign. They're less than 5 centimeters, they're real small, they can be benign. The larger they are, the greater chance they are being malignant. Increasing patient age also will kind of lead you towards maybe something's more malignant within an older patient. The strongest risk factor is in the case you are already having ovarian cancer or even breast cancer, and that's due to like a genetic makeup thing. Clinical symptoms include vague abdominal pain, swelling, indigestion, frequent urination, constipation, and a weight change. And this is due to ascites. You're getting all that fluid built up on you, so you'll get that abdominal distension, is that on there, and pain and swelling. And so again, you'll get that weight gain. Okay, so this is the stages. This is on the next page. And this, typically there are 4 stages of cancer. Stage 1 is always going to be like limited to whatever that organ is. Like lung cancer, that's going to be limited to the lung. Ovarian cancer is limited to the ovary. And then stage 2 is where it's limited to just like that area. For this, it's limited to the pelvis. If you had, kidney cancer, stage 1 would be on the kidney. Stage 2 would be like in that capsule area, like in the perirenal space. And then stage 3 for ovarian cancer is it's limited to the abdomen. So it has spread to the abdomen, but not like all out to, the brain and lungs and everywhere else. And then stage 4 is where it has spread beyond the abdomen and it's just gotten everywhere. And that's stage 4 of any cancer. It's just spread all over the place. Okay, Doppler findings in ovarian cancer. If there is an absence of blood flow within a lesion, it is going to typically be benign. Alright, because remember, cancer needs this blood flow. Malignant tumor growth is dependent on angiogenesis, which that's vessel formation, with the development of abnormal tumor vessels. So you're going to see those intratumoral vessels. You see a mass, the blood flow on there, you see those vessels in there. The chances are it's going to be malignant. And this leads to decreased vascular resistance and a higher diastolic flow. So you're going to have that low resistance waveform where you got your peak systolic will be up here and then your diastolic will be up here too. So you have a higher diastolic flow velocity. Alright, epithelial tumors highlight the first 3 sentences. Alright, gynecologic tumors that arise from the surface epithelium and cover the ovary and the underlying stroma are termed surface epithelial stromal tumors. This group accounts for 65 to 75% of all ovarian neoplasms and 80 to 90 of all ovarian malignancies. So these are the common types. The 2 most common types are serous and mucinous tumors. Now, serous tumors have a serous fluid within them. It's more liquidy. It's like a serum. Whereas mucinous is more like slow. It's like gelatinous. If that's how you say that word. Gelatinous. Is that how you say it?
Yeah.
Okay, gelatinous. So it's like gelatin. Every time I hear that, I'm looking at logo or something.
Like snotty nose.
Yeah. And so it's kind of oozy and it's thicker. That's what the mucinous tumors are filled with. Alright, so mucinous cystadenoma, that is a type of epithelial tumor. And it is lined by the mucinous elements of the endocervix and the bowel. When benign, it is called a mucinous cystadenoma. When malignant, it is cystadenocarcinoma. So if you hear carcinoma, you know it's going to be cancer, as well as sarcoma. You hear those, you know it's going to be cancer. But again, these mucinous cystadenoma, this is the benign form, so it's going to be benign. These can become very large. They can measure up to 30 centimeters, and they can even weigh more than 100 pounds. They can get very large. And then they can be simple or septated, thin walls, multilocular cysts, and they have this mucoid material in them because they are mucinous. And here is a mucinous cystadenoma. And, okay. I want to tell you the next one. Okay. Mucinous cystadenocarcinoma, this is the malignant form. It accounts for 5 to 10% of all primary malignant ovarian neoplasms, so it's not super common. It can also become very large. These mucinous forms can become very large. And then the malignant form is more likely to rupture than the benign form. And whenever it does rupture, that mucoid tissue, that mucoid substance, that gets out into the abdomen. So it's like ascites, but it's not like a serous fluid. It's a mucoid substance. So this is called pseudomyxoma peritoneum or peritoneum. Instead of the UN, you may see it with an I at the end. Same thing. So pseudomyxoma peritoneum or peritoneum. And that's this escaped mucoid substance, mucinous gunk. The most common cause for this I don't think we went over this, so never mind, different class, I won't even get into that right now. But if you had a mucinous tumor that ruptured, this will occur. And this causes loculated ascites with a mass effect. Alright, under sonographic findings, malignant cysts tend to have thick, irregular walls instead of like the thin, smooth walls, like a simple cyst. And they'll have septation instead of being just completely anechoic. However, these do have an appearance similar to serous cyst adenocarcinomas. So these all kind of look the same. You're not going to be told to tell if this is mucinous cyst adenoma or serous cyst adenocarcinoma. Like, that's not up to you. You just have to describe what you can find. Because histologically, that's what you're going to have to, that's how they're going to tell the difference. They're going to have to biopsy, be able to see the makeup of it. Okay? Let's see. Alright, so moving on. Here is an image of a mucinous cyst adenocarcinoma. See how crazy it looks. There's it again in another view. Alright, cyst adenoma. That is the second most common benign tumor of the ovary, where it's just a cyst adenoma. So that's going to be benign, whereas cyst adenocarcinoma is going to be malignant. This is the second most common type, though, after the dermoid cyst and that teratoma. The dermoid cyst we talked about, like teeth and hair and all that, that is the most common benign ovarian neoplasm. These serous cyst adenomas are usually unilateral, and they are usually unilocular or multilocular with thin septation. So they will have those bright echogenic-like bands throughout, and those are the septations. However, serous cysts are smaller than the mucinous ones. Okay, so they can, however, they can become, pretty large as well. They're just typically not. They don't typically grow to become as large as mucinous. Let's see, their borders are irregular with a loss of capsular definition. Alright, and here is us a serous cyst adenoma. So see, it can kind of look the same. You've got your fluid, and you've got your septation on the ovary there. There's another one. Got your septation and your fluid. Alright, this is adenocarcinoma. This constitutes 60 to 80% of all ovarian carcinomas. So this serous cyst adenocarcinoma is more common than mucinous cyst adenocarcinoma. More than half of these tumors are bilateral. So the serous cyst adenocarcinomas tend to be bilateral. And this is kind of it's not like a rule, but just in general, something that's malignant, if it's going to start like spreading or whatever has caused it, it's typically going to affect both. So they may be bilateral more so than something that is benign. Alright, so malignancy will have a higher chance of being bilateral than something that is benign. Okay? Alright, so sonographic findings, again, they're going to be like kind of smaller than the mucinous cyst, but they still have the irregular borders, and then the loss of the capsular definition. So same thing. They can look the same. Again, we can't tell the difference. They're going to have to get like biopsies, all that good stuff. Okay. Here is I had this earlier with the complex mass. Sure, but there's some little cancer in there. See, just kind of looks irregular and echogenic. There's another one. This one's actually been Doppler. You see that low resistant waveform, the high velocity of the diastolic flow here. See, it's like close to almost being the peak systolic. All right, germ cell tumors. Highlight the first line. They are derived from the primitive germ cells of the embryonic gonad. So germ cell tumors from the germ cell of the embryonic gonad. So that's either going to be the ovaries for the female and then the testicles for the male. Approximately 95% of germ cell tumors are the benign cystic teratomas or the mature teratomas. That's the dermoid cyst. That's another name for it. Same thing. All right, highlight the last sentence of that paragraph where it says they are associated with elevated alpha-fetoprotein and HCG levels. Clinical symptoms include pelvic or abdominal pain and a palpable mass. If you think like how I always would put these together was that, these germ cell tumors, yes, they are associated with elevated AFP and HCG, and then they come from the germ cells of the embryo, of the embryonic gonad. So I'm thinking embryonic gonad, this is alpha protein and HCG. This is when you're pregnant with an embryo. I just would lump all that together and would know, oh, that's with the germ cell tumors. And then, if they get real big, they can cause pain and a palpable mass. If they're real big, you'll be able to feel them, and they can impinge on other structures and cause pain. Alright, next page, teratoma. Dermoid tumors are the most common ovarian neoplasm, consisting 20% of ovarian tumors. So, dermoid cyst, that is the most common neoplasm. Malignant degeneration into squamous cell carcinoma may occur. Squamous cell carcinoma is a type of cancer, and a dermoid cyst can degenerate into this and become malignant. Dermoids have a spectrum of appearances on ultrasound. They can appear cystic, complex, solid, they have echogenic components. It just depends on what they're made up of. Under that second paragraph for sonographic findings, that can tell you about, that kind of lists the different types of appearances it can have. But also it can be described as tip of the iceberg. Remember, there's something that is bright and echogenic. You'll see the white, and then it'll get darker because of the shadowing coming down from it. But dermoid cysts can look all different kinds of different ways because they can be made up of such different substances and components. Okay, so here are the 5 typical that you can see. It can be a completely cystic mass, or it can have echogenic nodules in there. It can have fat in there with fluid. It can have teeth or bone that causes shadowing after you have that bright echogenic focus in there. And then it can, be a complex mass of internal septations. So they can look all different which ways. Here is a dermoid cyst. So we've got some septations and then some kind of hard mass like right here. Here's another one. Here's another one. This one, I was trying to find you guys one with hair and teeth, because not all of them have hair and teeth, but this one does. Here's hair here, here's some teeth. They kind of joke about, it's like you ate your twin or something. I don't know, or like your twin was conjoined to you or something, and you just absorbed it. But, for sure. Alright, but that is a teratoma or a dermoid cyst. Alright, now immature teratomas. Now a dermoid, don't get confused because like a mature teratoma, I don't even like how this book added, how it says immature and mature teratomas. Just cross out immature because I'm not even talking about immature in this section. I'm only talking about immature. But a mature teratoma is a dermoid cyst. It's going to be benign. However, it can degenerate into squamous cell carcinoma. But in immature teratomas, those are uncommon. They tend to occur in girls and young women. I always would think, immature teratoma, someone that's immature is probably going to be like 8 or 9, maybe 13, 14. They're going to be younger. And these are rapidly growing, solid malignant tumors with tiny cysts. So these are going to be malignant. Whereas mature teratomas are benign, immature are malignant. They are usually unilateral, and small in size. And then they can range from cystic to complex. Alright, dysgerminoma, highlight that first sentence. This is a rare malignant germ cell tumor. It's usually unilateral, but it's bilateral in up to 15% of cases. An entirely solid ovarian mass in a woman that is younger than 30 years of age is usually a dysgerminoma. So if you're out there scanning a woman less than 30 years old, see a good solid mass that's not all crazy looking, so it's not going to be a dermoid cyst, chances are it is going to be a dysgerminoma. It is one of the most common ovarian neoplasms seen in pregnancy. And these are hyperechoic solid mass with areas of hemorrhage and necrosis. So they'll be hyperechoic, however there can be like some hypoechoic components in there because of the necrosis. Let me make sure that's something I gotta tell y'all. Oh my God. When did you came for, you just missed your first class? Okay.
Oh, my gosh, like, where were you at this time? We're in the hospital.
Alright. Okay. Alright, endodermal sinus tumor. These are rare as well, and they are rapidly growing tumors. They're also called yolk sac tumors. Increased serum ASP may be seen, so that increased alpha-fetoprotein can be seen. These do have a poor prognosis, and the sonographic appearance of these are similar to a dysgerminoma. Alright, stromal tumors. Sex cord stromal tumors typically are solid adnexal masses that arise from the sex cords of the embryonic gonadal or ovarian stroma. Sarcomas and fibromas are the most common of these. They are benign, solid, hypoechoic adnexal masses that occur in middle-aged women. So fibromas and sarcomas are benign. They are hypoechoic on ultrasound. They are most commonly seen in middle-aged women, and they arise from, the ovarian stroma, that ovarian tissue. Alright, down to fibroma and sarcoma. They both arise from the ovarian stroma. Tumors that have an abundance of Theckel cells are called sarcomas. And if they have an abundance of fibrous tissue, then they're called fibromas. Right? Easy to remember. Sarcomas frequently show signs of estrogen production, whereas the fibromas don't. So sarcomas can actually produce estrogen and secrete the estrogen, however fibromas don't. And these are also associated with ascites along with pleural effusion, and this is referred to as Meg syndrome. So this is like you have to have like a triad of issues. You got to have some kind of ovarian neoplasm. You got to have an ovarian neoplasm. You got to have ascites, that's floating abdomen, and you got to have pleural effusion. You got to have fluid around your lungs. So you got fluid around the lungs, fluid in your abdomen, and an ovarian neoplasm. That triad of issues there is called Meg syndrome. Okay? Here is a sarcoma.
Now see, I get counted off for that.
What?
It's too bright.
Yep. It is. It looks like a really old picture that's been used a bunch of times, and it's just been scanned so many times. But yeah, it was the only one that I could find in, a short amount of time. And then here is a fibroma. Solid mass. Hypoechoic. Okay, granulosa. Oh my God. What have y'all been doing today? Y'all making so much trouble.
Yeah, she just on it today. I think she's gonna let you mix her.
Okay, a granulosa, that is, highlight the first line, that is a feminizing neoplasm composed of cells resembling the Graafian follicle. So estrogen, this can be called a hormone-active estrogenic tumor because it can produce that. Down to clinical symptoms, estrogen production may include precocious puberty. Remember when we talked about precocious puberty? You've got like a 3-year-old looking like a 15-year-old or 17-year-old. It can cause precocious puberty or vaginal bleeding and full breasts. Cause your little girl turn into like a woman way quicker or look like one. Of course she should. Pain, pressure, and fullness may also be present. The tumor may twist on itself to cause torsion or rupture. If this rupture occurs, then this can lead to Meg syndrome because fluid will get out to the ascites. Fluid get out to the abdomen. And then again, it can have a variable appearance because this is an ovarian tumor. Typically, they all have variable. They can vary in their appearance. All right, so let's move over to metastatic disease. Here I got a picture of granulosa there. What? Ready? Alright, so metastatic disease, we're going to skip those other two. The ovaries are more involved with metastatic disease than any other pelvic organ. So you'll get metastasis to your ovaries before your fallopian tubes, your cervix, your vagina, your bladder, your uterus, your rectum. Larry's like, yeah, that's good.
That's when the fun begins.
Alright, metastatic cancer can arise from the breast, upper gastrointestinal tract, and other pelvic organs by direct extension or lymphatic spread. Now this is important to know because this is on your registry. They loved asking me this question on my OBGYN registry. I'm pretty sure it's on my abdomen as well. The Krickenberg tumors are drop metastasis to ovaries from the GI tract, primarily from the stomach, but also it can be from biliary, and the gallbladder, and pancreas. So just biliary tract. But most coming from the stomach, and this is where it has the mets has dropped or just it's come down and it's just hit the ovaries, so it's spread to the ovaries. So if you've got like just a tumor like the bowel or the GI tract that has gone to the ovary, that's called a Krickenberg tumor. Okay? Remember that. Okay, because that's going to probably be on your OBGYN registry and maybe even on your abdomen. Alright, sonographic findings. Metastasis is usually completely solid or solid with a moth-eaten cystic pattern that occurs when necrotic, I guess it's just stop right there. I don't know.
Yeah, this one maybe occurs on it.
Okay, occurs when necrotic. Gotcha. Alright. And here is our Krickenberg tumor. So there's that.
Okay.
And then there's another one. That's our Krickenberg tumor. Alright, and then our carcinoma of the fallopian tube. This is the least most common gynecologic malignancy. So you'll have uterine cancer before you'll have fallopian tube cancer. And the sonographic appearance is, a sausage-shaped complex mass with cystic and solid components, often with papillary projection. So it can be complex appearance. It'll have cystic and solid components. It'll have like projections into it. And then this is what it will kind of look like. Little sausage, a little S shape there with some masses in there. Okay. Okay, Finley's ready to go.
Look, I did my paper. You're right at the end, so close on with the end.
And we're gonna take turns reading the sentences for the next.
Are you gonna give us candy if we get it right?
Well, we got time left, let's go to the next chapter.
That was like, we had desperately
On
had,
time.
no, we had a horribly long chapter in chemo and then in here.
Kind of. They're coming back. Got outfit sales. Oh, people.
But we should know what, and
Yeah.
No, not everybody.
Find something that is,
You want this
I
now?
would always find something that was specific.
You want this now,
Well, it seems like all of them is
Certain thing that is specific to that one. This one's not gonna be like a big roll test, actually, there might be like 50 questions.
What?
You can't find anything.
Whoa.
You really are sick, Miss Pound.